I'm Dr. Richard Sim. I'm a general and colorectal surgeon. I see patients with problems like bleeding per rectum, change in bowel habit, abdominal pain, and they may turn out to have things like hemorrhoids or cancers of the colon and rectum. So that's my area of practice. In terms of prevention of colon and rectal cancer, the most useful or certainly the most effective means would be screening. And there are a few modalities that can be used for screening. The most proven effective by studies are the fecal immunotesting for occult blood or colonoscopy. 10 years ago, if I told a patient he had cancer, he probably would say, "How long have I had this?" I think now, and I'm happy to say, more patients are actually asking me, what stage is it? What can I do to improve my chances of getting cured? I think that's a big step towards empowerment. It's not just educating, like I say, it is more engaging them, inviting them to take charge, and then developing an environment that is encouraging of it. So I think good outcomes are given. Bad outcomes are the ones that I feel we should not be afraid to accept. Certainly, many times they may be avoidable or preventable, and that's the essence in which we should look at them, how we can learn from these bad outcomes so that we can correct what is not good and go on to achieve even better outcomes.
I'm Dr. Ming Hian. I'm a colorectal surgeon. My specialty is mainly in minimally invasive colorectal surgery, and we treat a wide variety of conditions, including colorectal cancer, piles, hemorrhoids, as well as fistulas and diverticular disease. In the past, what we used to do is open surgery, and as you know, open surgery comes with a huge scar, it's a very big scar, and patients' recovery was slower as a result of the pain as well as the need for recuperation after the surgery. Nowadays, with laparoscopic surgery, all the surgery is done through very small keyholes within the abdomen, and it's also called minimal access surgery. So the skin incisions are very small, but the surgery that's performed in the abdomen is still almost the same as the open surgery. So we can get the same quality of surgery, but with much smaller wounds. And therefore, the patient recovers much faster. In terms of teaching, laparoscopic surgery also affords better visualization. As you can imagine, if you do an open surgery, when the surgeon wants to teach his students, they can't see what's going on. They're looking over his back, and that's what our experience was when we were training. But now with laparoscopic surgery, everything is beamed externally onto a huge monitor. Anyone in the operating theatre can see what's going on. I think Farrer Park Hospital offers state-of-the-art equipment. For example, in the operating theatres, we've got very good high-definition monitors which allow us to visualize the internal anatomy of the patients with pinpoint accuracy. And that helps us in our surgery as well, because it allows us to identify the anatomy correctly and minimize damage to any parts of the internal anatomy.